Thank you so much, Allison. And I really want to thank FASPEN for inviting me here today. It's so nice to be back in Georgia. And we were chatting last night and I was like, oh, I was president of FASPEN and I couldn't remember what year that was when I was in Augusta. What was it? 2000, Marlene, look it up. So it's so nice to be back here and really to talk about one of my favorite topics, the gut microbiome. So we're gonna carry you through this today. My main objectives are to review the gut microbiome in health, and then we're going to discuss changes to the microbiome during critical illness, and we'll discuss evidence for microbiome manipulation in critical illness. I think I glazed, these are my disclosures, but they don't pertain to what I'm speaking to, and everything I'll talk about today is evidence-based. So just to give a quick summary, we've all heard about gut microbiota, gut microbiome, and what's going on, and we're learning every day as technology advances, what is really happening within our microbiome. And just on this slide is just showing, we have trillions of microbes within our gut, predominantly in our distal gut is where we see the numbers climb up to 10 to the 12th colony forming units per gram of feces. These microbes are a composite of, bacteria, fungi, viruses, archaea. But what we know most about is the bacteria. We're starting to learn more about the virus, the virome, and we're starting to learn more about fungus. But mostly it's bacteria that we have knowledge on. We know there's 7 major phyla within the gut microbiota. And in a healthy state, and that's still under debate now, what actually is a healthy gut microbiota? What does that mean? But we see predominance of Bacteroidetes and Firmicutes, comprising about 90% of the bacteria within our gut. And within our gut, within these phyla, there's over 800 species and 7,000 strains. So that's what's interesting when we get into, talking about more of the details of what's going on within the gut microbiota, is that it's this really complex ecosystem that we have. And we know that it's important to us. And we think about, when we first started talking about gut microbiota back in the 2000s, started to really emerge. We used to think we just had a commensal relationship with our microbiota, in that only the microbiota benefited from us, providing a safe place for them to reside. We feed them every day with what we eat. But we started to learn more and more is how important the microbiota are for us. So we think of it more of a mutualistic relationship, in that the microbiota help us synthesize different vitamins, hormones, enzymes. They produce a lot of these other postbiotics that we're starting to learn more about as well. And that of these metabolomics, or these metabolites that are produced, they have interactions not only within our gut, but we see that they're very important in other organ systems in our body. And so we think about this slide here, all of these metabolites and the interactions with the microbes, and then all the genes and the proteins involved with these microbes, and how they benefit the host. They help support everything I already mentioned, but also they help to keep these pathogens that we are ingesting every day through our food and water supply, help to keep them at bay through many different mechanisms that we're starting to learn about. They help to maintain this gut barrier to prevent bacterial translocation or bacterial byproducts into systemic circulation, which can activate our immune system and cause a lot of these problems that Lintek was just talking about with sepsis and SEERS. But also we know that in response to the gut microbiota, the host responds. So we have this top-down approach. So there's this crosstalk that occurs between the microbiome and the host cells. And like I mentioned, diet, what we eat every day really impacts our gut microbiota, but all these other factors are known to impact the gut microbiota as well. And we think about medications and think about our patients, and antibiotics destroy pathogenic bacteria, but they also attack these good bacteria within our gut. And this is where we can see, we can have overgrowth or these blooms of these more opportunistic pathogens occur within our gut. We'll talk more about that in a little bit. geography. So not only within the world, you know, like where you are residing, what you eat and drink, and what microbes are in your soil and your water supply will affect, you know, your microbiome. But also now think about your patients, okay? And they're at home, that's one environment, and now they end up in the hospital, in the intensive care unit. It's a whole different geography for them, if you think about it that way. And that all impacts the microbiome. We know there's changes throughout the life cycle. So an infant is considered, you know, sterile until the first birthing process is where we start to see colonization begin. And then through the feeding method. And then about the age of 3, the microbiome is what we'll resemble as an adult. But all of these factors occur during our life cycle, so that we know that the microbiome of a young adult is very different from one of mid-adulthood to the elderly. And so we see these changes, and these are other things to think about when you consider your patients, and you can't treat them all the same. Their microbiome isn't the same just based on their age alone. And then stress. Stress is an important factor on our microbiome. We're starting to learn more about the gut-brain axis and how psychological stress can impact the microbiome, and that whole sense of that gut feeling, you have a gut feeling about something, is really true. And we see the signaling now through some of the byproducts of the microbiota are these neurochemicals, these neurotransmitters, serotonin, GABA, dopamine, that can now signal to the brain and vice versa. But we also see, even with exercise or metabolic stress, which we'll talk more about. So that's a healthy state. So what's happening when we our patient comes into the intensive care unit environment, and what's going on there? So think about the common therapies that happen to our patients. So first, about the diet. How are our patients being fed? Either they're not being fed at all, or they may be getting some enteral nutrition, but it may be suboptimal enteral nutrition, meaning that it's very low rate. So they're only getting, you know, 10 to 20% of their nutritional requirements. And then what are they being fed? They're being fed these artificial sterile formulas that really contain little to no fiber. And so fiber being one of the, particularly soluble fermentable fiber, being one of the main predominant preferential food sources for the microbiota. So the microbiome are not receiving this. Or if they're on parenteral nutrition, of course, non-luminal delivery of nutrients with sole parenteral nutrition, and just parenteral nutrition itself outside of the ICU setting has been shown to cause gut dysbiosis. Then, of course, most patients are getting at least one course, if not many, antibiotics, or they're on acid-reducing agents. So if we elevate the pH in our stomach, that's one of our first lines of defense of any ingested pathogens. That low pH in our stomach helps to destroy these. So with PPIs or histamine 2 antagonists, we go against that. And so now these pathogens can survive and move down to our distal gut. Lintek talked about the shock, the sepsis. These low flow states can also impact. So that's a whole environmental change going on within our body. So you think about how the human is responding to this change in the physiologic environment, but the microbes are also being exposed to that change in physiology as well. And how do they respond to that? So thinking of the microbes within our gut, it's an anaerobic environment. And then if we're doing resuscitation, and is that oxygen now getting to the gut, and that's also changing the microbiota profile. So with all of this, you know, what's happening? So the microbiota really have to compete for limited nutrient resources, and they really have to be able to survive under these harsh and hostile conditions that they're being exposed to. So what ends up happening to the microbiome in the critically ill? And there's been a number of papers now that have really interrogated and really tried to characterize what's going on in the microbiome. This is one that was published recently, that they looked at 115 critically ill patients. They got stool, skin, and oral swab samples on patient admission to the ICU, and then again on ICU discharge. And the control subjects came from samples that were deposited with the American Gut Project. So these are healthy people that have also provided these samples. And when we did a comparison, looking at the principal coordinate analysis of unifrac distances, so this is the beta diversity. So how are the populations dissimilar to each other? I've just circled here the fecal samples from the American Gut Project. And then these are the fecal samples from the patients in the ICU. And what is this showing is that there's a clear separation in the microbiota composition between these two populations. But when we look at the phyla, like what's going on there? So this is big picture phyla. We talked about the 7 major phyla, Firmicutes and Bacteroides being the predominant. So just looking here, this is on admission, and you can see, just look at the color changes. Excuse me. The red is representing the proteobacteria. The green is the Bacteroidetes, and the blue is the Firmicutes. So you can see, even on admission to the ICU, there's an overabundance of the proteobacteria in the patients, and these are the healthy controls down here, and how this becomes even more predominant on ICU discharge. So why we're concerned about proteobacteria, it's a phyla, but it also contains many of our gram-negative microbes that are what we consider opportunistic pathogens. So I want to present this paper. It's really interesting how quickly does this occur? So I just showed that on admission to discharge, but this paper looked at changes in the gut microbiota immediately after severe and sudden insult to people. So they looked at 15 people and compared it to 12 healthy volunteers. And these patients sustained trauma, cardiac arrest, or cardiovascular events. They did rectal swabs within 6 hours of admission to the emergency department. Excuse me. And this was before antibiotics were provided. Then they serially collected stool samples until day 14 at these different time points, because all these patients got admitted to the hospital. What they found is at day 0, so before that antibiotic, there was a 1,000-fold decrease in the commensal microbiota in these patients. And predominantly, there were these obligate anaerobes were most affected. So this is where Lactobacillus, Bifidobacterium fall in that category. And as looking at the metabolic byproducts, there was also a decrease in the short-chain fatty acids. We'll talk more about what that might mean. There was overgrowth of pathogen over the course of the 2 weeks with predominant Enterococcus and Pseudomonas. And there was no recovery of these commensal microbes or the short-chain fatty acids throughout the ICU stay. So the authors were like, well, what's causing this? You know, just this sudden metabolic insult caused this dramatic change. And they kind of hypothesized that probably the metabolic insult itself and this hypoperfusion to the body, to the gut. And then with the resuscitation, introducing this oxygen that then can affect these anaerobic microbes, as I mentioned earlier. So here, you know, thinking about these are, you know, younger adults were in that population, but what happens to people who are older? And here they defined older as someone older than 60 years old or less than 60. And this was an observational multi-center study of 5 intensive care units in Colombia. And here they looked at stool samples, they did a rectal swab, and then on ICU admission, before any nutrition started, and then an ICU discharge. And they used 16S ribosomal RNA sequencing and analyses to interrogate the microbiome. And they looked at alpha and beta diversity, as well as they looked at differential diversity and abundances were also analyzed. So here, you can just see in this top panel, these are the bacterial phyla that were analyzed. And here's the population that's under 60 years old. And again, just look at the color changes. So here the purple is the proteobacteria. And you can see just by age now, there's a difference in overabundance of proteobacteria that occurs in these populations. And then looking at the alpha diversity, so this is intra-individual variability. you could see that there's a significant difference in the alpha diversity. And alpha diversity also measures the evenness and the composition and evenness of the microbiome. So you can see those that are older than 60, a little bit lower alpha diversity. And looking again at the beta diversity, you can see there's separation not only by age, also they looked at it by gender, and showing that the females, it's a little bit hard to see here, but the females had a little bit alteration, more even diversity than the males did. So this is interesting that age, we're now seeing that age is making a difference in an ICU population as well. Concerning that there's this overabundance of proteobacteria in people older than 60. So I mentioned about the antibiotics and how antibiotics destroy pathogenic bacteria, but they also attack the good bacteria as well. So what are the effects on immunity? So we think about our gut is our largest immune organ in our body, and how does this impact how the antibiotics are attacking our good bacteria in our gut and our immune defenses? And this is an interesting paper because it looks at different types of antibiotics and different antibiotic combinations, not only in how it affects the microbes, but it also affecting the different immune properties within the body. So this is, you know, kind of alarming that here we are seeing that this crosstalk that goes on between the host cells and the microbiota, and how this can impact overall, you know, thinking about your patient population. Which brings me to this paper, and I love this paper. If you have time, I suggest that you read this paper. It's published in 2014, but it's very interesting to read. What they did is they looked at patients in an ICU, a total of 14 different patients. So it's more like a case control kind of paper, and they compared it to healthy controls, 5 healthy controls. And they looked at the composition of fecal samples by 16S ribosomal RNA sequencing, and they collected stool samples at several time points throughout the patient's ICU stays. They looked at antibiotic resistant profile of isolated pathogens from the stool. And overall, when I said this ICU population is a very diverse ICU population, and so patient stays varied to less than 10 days. Some patients were there for more than 30 days in the ICU. These patients were very sick. Of them, 7 of the patients ended up dying after their ICU stay, and the mortality was associated with sepsis. In this paper, they also looked at cultures from other sources. So they looked at stool cultures, but also sputum, blood, urine cultures on the patients. So just looking at the microbiota of these patients. So looking at the healthy controls, I've got that boxed here on top, that they were predominated by the dominance of the 2 major phyla that I mentioned, Firmicutes and Bacteroidetes, showing in this green and yellow color. And Proteobacteria, which is in blue, remain very low in the healthy controls. What's interesting in the ICU population, 50% of the patients were dominated by Proteobacteria or Firmicutes at least one time point. And what's interesting is over time, you can see how in some of these patients, it dramatically just changed, where they started out with the dominance of the Firmicutes or Bacteroidetes and then shifted to the Proteobacteria over time. When looking at the diversity, here they looked at Chow-1 diversity index. And here, these are healthy controls. Their diversity was high. It was, and it comprised about 40 bacteria genera. But the ICU patients had a decreased diversity. More than 80% of the samples had a Chow-1 diversity index less than 50. And about 50% of the samples, the index was less than 10. So of the microbes that were there, very low diversity, dominated predominantly by Proteobacteria. And when we look more at the genus level, Escherichia enterococcus dominated in 7 of the patients. So these are your pathogenic microbes. So looking at, like I said, they go through individual patients in the paper, and I pulled this one patient out because I think it's an interesting story to tell and think about some of your ICU patients that you might have. So this was a patient that was awaiting liver transplant, and he ends up dying of severe sepsis after 8 weeks in the ICU. On ICU day number 1, Enterococcus predominated about 99.9% of the reach, shown here in this blue color, looking at the stool sample. And when looking at the culture analysis, it presented a 2-member community of multiple drug-resistant microbes as Enterococcus faecium and Candida albicans. On ICU time point 2, which is 23 days later, you can see the shift from Enterococcus to Enterobacteriaceae in this purple color. And then looking at the culture reads, again, it was dominated by these 4-member community that were multi-drug resistant microbes. When they looked at the urine and the blood cultures of these individuals, they were positive for Candida albicans and for Enterococcus. So again, the same microbes that are growing in the gut are what's showing up in the urine and the blood of these patients. And looking here, they did this antibiotic resistance profile of isolated pathogens from the stool. And these pathogens were resistant to multiple antibiotics. And when they look back at a retrospective analysis, they found that the antibiotics were aggressively being administered to treat these infections that were showing up in these other biospecimens, but however, they weren't able to clear these infections in the patient. So, the authors are, kind of hypothesizing here that were these infections in these other biospecimens in the urine and the blood showing up and not going away with the antibiotic treatment because they were kept being reseeded from what was going on in the gut. There was gut barrier disruption and bacterial translocation into circulation, and this is where this continual source vicious cycle was going on. So what might be going on in this situation? So we think about the healthy microbiome, like I mentioned, does a lot of beneficial things for us. And one of the main things is this competitive exclusion of these pathogens. And it does this by multiple ways. So pathogens invade the host cell in different manners. Some may just attach to the enterocyte and then through endocytosis get into the cell. Some pathogens set up these tier systems on the outside of the enterocyte that project into the mucus layer, into the gut lumen, and others may just invade the mucus layer and then get into and start to erode into the enterocyte. And so what the good commensal microbes do is they can help protect against that. Either they secrete their own antibiotics, which are called termed bacteriocins, so certain microbes can do that. They may just block that adhesion site for those pathogens. By taking up an adhesion site, then the pathogen can't adhere. Or they may secrete some anti-inflammatory cytokines or some other protective factors that can protect against that. So that's a healthy state. But what's happening in the critical care setting is this is all wiped away. So with this overgrowth, there's a bloom. And so with the commensals being decreased, we don't have this protective effect. And that's why potentially we're seeing these negative effects. So this is another paper that looked at, I mentioned about the beneficial byproducts that the gut microbiota produce for us. And one category of these are these short chain fatty acids with acetate, propionate, and butyrate being the predominant short chain fatty acids being produced in a healthy state. This paper looked at patients with systemic inflammatory response syndrome. They looked at 140 of these patients and compared it to 14 healthy controls. These patients were all being fed enterally through a nasogastric tube. They did receive antibiotics based on susceptibility testing. They also received histamine 2 antagonists daily. They monitored fecal samples, were collected weekly until ICU discharge. And these stool samples were then analyzed for short chain fatty acids. And then they did microbiota analysis by a little bit old-fashioned method of agar plating. And then they also looked at fecal pH, because a low pH in the distal gut is also a protective mechanism against pathogens, which prefer a higher pH for survival. Interestingly, just looking at the agar plating of these fecal samples from these patients, you can see here there was significant differences between the patients with sears versus healthy volunteers, significant decrease predominance of these different microbes. What I found very interesting is that Lactobacillus as a species was not significantly different between the two groups. And why I find that very interesting is that if you think about what are predominantly our probiotics that we have commercially available that we give to patients, they're of Lactobacillus species often, and that's just because these are facultative anaerobes, like I mentioned, and they can handle oxygen, and they're a lot easier to manipulate, and they survive better. And so to generate probiotics from Lactobacillus is a lot more feasible than some of these strictly anaerobic microbes that we have, because it's hard to massively produce these. Looking at the short chain fatty acids, all of these were decreased, as well as pH was increased in the patients with sears compared to the healthy controls. And the short chain fatty acid levels as a whole, putting them all together versus individual short chain fatty acids, were associated with the incidence of enteritis in the patients, as well as gut dysmotility. So low levels of short chain fatty acids, higher incidence of enteritis and dysmotility. So why am I talking about short chain fatty acids? What's the big deal? Well, it's based on my research, but I'm not going to be biased there. But we know a lot about the short chain fatty acids. We've been studying it for decades. And particularly butyrate has been shown to be one of the most predominant ones and shown to have many beneficial biological roles in the body. So butyrate is our primary fuel source for our colonocytes. It also helps to enhance water and electrolyte absorption. It supports gut barrier integrity. So when there's incidence of decreased butyrate in the colonic lumen, there's also increased incidence of gut barrier disruption and leaky gut, as you may hear that terminology. Butyrate also helps modulate the immune function, not only within our gut, helps with T regulatory cell differentiation, but we also see it's beneficial in other organs in the body. And why that may be, like, why is something going on in our gut having a beneficial role in our brain and our lungs and our liver? That's because there's these G protein coupled receptors that are expressed in other organs in the body, where the short chain fatty acids or butyrate are the ligands for these receptors. And these receptors, when they interact with these short chain fatty acids, are anti-inflammatory and immune modulatory. And so this is how what's going on within our gut, particularly with short chain fatty acids, can have a beneficial role in other organ systems in our body. Also, a lot of disease conditions, chronic conditions, are not only associated with gut dysbiosis, but a decrease in butyrate generating microbes, as well as a decrease in butyrate and other short chain fatty acid levels. So to just summarize, this is from John Alberti, just what's going on with our ICU population. So not every patient, as you know, coming into the ICU has a prolonged, horrible stay. People survive and get out and have a normal life after. So why is there a difference? What's happening? And if we look at it from the perspective of the microbiome, so we have somebody that comes into the ICU, they may or may not have, what's going on in the microbiome itself on admission. And then you think about how they're fed, if they're NPO, if they have surgery, if they get antibiotics, and then how with the resumption of normal feeding to the patient, and then with more of the unprocessed food, but then allowing for the microbiota to refaunate within itself. And then we see this beneficial in recovery of these patients. But what happens with severe injury is the same scenario starts, but now there's this prolonged starvation in the ICU, either through of the gut. So if you think about starvation of the gut microbiota, not being fed, the optimal nutrition, fed parenteral nutrition. So again, we're not supporting the gut microbiota. And then then they get multiple antibiotics, this bloom in these proteobacteria phylum, and then overgrowth of these pathogens, and then unable to then regenerate and refaunate these good commensal microbes, which leads to this vicious cycle going on in our patients. So what can we do about it? Or should we do anything about it? I think that's, the loaded question. And so different ways to manipulate the microbiome. We have, looking at fecal microbiota transplant, but I'm not going to really talk about that for the critically ill, but looking at probiotics, prebiotics, or symbiotics as a way to do this. And I think it's important to understand, what is a probiotic? I talk about this all the time. And the World Health Organization is that it's a live microorganism which, when administered in adequate amounts, confers a health benefit on the host. But what does that really mean? And so that's very general, and everyone always wants to try to lump one probiotic is equal to another probiotic, but they're not. They're strain specific. And so even within the same lactobacillus species that I mentioned earlier, there's hundreds of different strains of lactobacillus, and each strain has a different mechanism of action. And that's where I think a lot of the data that we're about to look at gets watered down, and when we try to look at the effect of probiotics. Looking at prebiotics, what's a prebiotic? Well, it's basically the bug food. So it's the food source for the microbiota. So it has to be something, it's usually a polysaccharide that we, the host, we don't have the enzymes to digest it. So it escapes digestion in our proximal intestinal tract, gets to the distal gut. Selective microbes within our microbiota are able to ferment or metabolize these polysaccharides. And as a result, they do something beneficial to us as a host. So they either produce some of these beneficial metabolites, or they, so there has to be some type of beneficial effect on the host as a result. It's a little bit difficult to demonstrate that because, again, all of this is going on within our distal gut in an anaerobic environment. And so it's very challenging to actually identify and characterize as a substrate as a prebiotic. A symbiotic is just a physical combination of a pre and a probiotic. And a symbiotic can be a general combination where maybe a manufacturer will just put something, because these are supposed to be viable microbes, and so they should be packaged as a supplement. They should be packaged with their food supply so that they can survive on the shelf in the drugstore or wherever you're going to purchase it from. And so that's just a convenience kind of general combination symbiotic. Or they could be a targeted symbiotic where you're purposefully putting together a microbe with its food supply to target an end product. And this is an area where, like, my research is really leaning towards this to try to target either butyrate generation or neurotransmitters, whatever it may be. So this is a moving forward area in a lot of people's research. So like I said, these probiotics, prebiotics, or symbiotics, it's based on what the substrate is and what the mechanism of action of it could be. So some probiotics have antimicrobial effects have been demonstrated. Some have been shown to enhance the mucosal barrier integrity, and some have been shown to have some immune modulation. And I think where people get really confused is they want to use something that may have been shown to demonstrate benefits on the immune function and use it for an antimicrobial effect or use it for bowel regularity. So these things, and then they see no effect. So it's really important to understand, what's the mechanism of action of the particular microbe, and to then try to project what your expected outcome might be. But nonetheless, looking at probiotics just in general, there's been a lot of data, lots of studies out, of course, over the last several decades, looking at the use of probiotics, not only in different gastrointestinal disorders, but as well as non-GI disorders. And I put little asterisks here because this is where there have been some positive signals for particular strains of probiotics for these different disease conditions. But here we're to talk about critical illness. But before we do that, just like Lynn talked about the limitations of a lot of the studies that he was presenting, there's a lot of limitations that go on with probiotic studies. And one is the studies all tend to be very small in size. So if they're less than 100 subjects, you got to think about, are they adequately powered? People coming to studies, everyone has their own different microbiota and their own different disease conditions. So that all plays into, how they may respond or not respond to an intervention. The dosing methods and what probiotic is actually being used really can impact, what the outcome will be. Are these products even viable? So I actually was doing some research years ago when I was in Augusta and working on my Ph.D. and I wanted to study a probiotic that we were doing clinically. And I went to the drugstore. I'm like, okay, yeah, that's what I'm going to do. I'm going to see if this really works. So I went to the drugstore, I bought it. I tried to grow it up in the lab and it didn't grow. I'm like, what's going on here? So then I went and bought some more and did it and it didn't grow. And I went to my friends there that were microbiologists and said, hey, what's going on? It's not growing. And they're like, Gail, you got to do what everybody else does. You just got to purchase it from, ATCC, which is a company that just has different strains of microbes. When I purchased the strain from ATCC and grew it, it grew fine. So that my end result was what I was buying in the drugstore wasn't even viable. So a lot of studies don't test for viability before they're actually doing the study. And then again, the fermentation substrate may be lacking. So if you're giving so if we have this overgrowth of pathogenic bacteria, patients not being fed, now you're giving one strain of bacteria, but it's no food supply for it, it may not have any beneficial effects. And then the other thing with probiotics is they tend to have more of a transient colonization. So, they're moving through the gut and through with peristalsis and may have an effect while they're there. It's kind of like a roller coaster. Woo, it's having an effect and then it's out the door. So so this is also some concerns to see, the effects of that. But with that, the downside of all that, what's going on. So thinking about the use of probiotics, prebiotics or symbiotics in critically ill population. So listed here is a table that came from this paper here that just looked at a bunch of different studies that had utilized either one of these probiotic or symbiotic. And you can see the different patient populations that were studied. There's liver transplant patients, other type of surgical patients, just general medical ICU patient population, trauma patients, patients with acute pancreatitis, and different probiotics and prebiotic combinations provided, what the outcomes they were predominantly looking for: infectious complications, ventilator-associated pneumonia. And you can see here, based on some of these different patient populations, there's significant benefit. In these medical ICU populations, these studies didn't show any benefit. And so, again, looking at these individually, positive plus or minus signal going on there. But now people want to do these meta-analyses and combine all these things together. And I already told you just 2 slides ago, the limitations of probiotics, but nonetheless, trying to put together randomized controlled trials. This was a recent one that was just published in Critical Care Medicine last year, testing probiotics or symbiotics, and they should have been provided to the patient at any length of time compared to a placebo or no treatment at all. This meta-analysis included 65 randomized controlled trials, about almost 8,500 patients. There were critically ill adults as well as children included. 13 of the studies had symbiotics, 52 had probiotics, and these were the most common probiotics that were used in the studies: Lactobacillus rhamnosus GG, Plantarum, and Saccharomyces boulardii. So in looking at this overall, just looking at the results, the probiotics were shown that they may reduce ventilator-associated pneumonia by 6.9%, healthcare-associated pneumonia by 5.5%, catheter-related bloodstream infection by 1.5%, other healthcare-associated infections by 12.2%, and the uncertain effect on Clostridium difficile infection and urinary tract infections. There was no effect on mortality, and they may reduce the duration of invasive mechanical ventilation, hospital and ICU length of stay. So they also, in the study, is interesting because they graded the papers and they looked at, the certainty of evidence for these different benefits. And if you look here, for ventilator-associated pneumonia, the certainty was low. Again, the healthcare-associated pneumonia was low. Mortality was moderate, and serious adverse events were low. So you can see there's a different, kind of starting to hint that the quality of the research study to then be able to interpret the clinical validity of the result. So this was a paper which is really interesting, came out this year in Clinical Nutrition. And they kind of took another approach that they wanted to look at the benefits and harm of probiotics and symbiotics in adult critically ill patients. So this was a systematic review and meta-analysis of randomized controlled trials. And they did this trial sequential analysis. So again, same randomized controlled trials of adult critically ill patients. They only included studies where there was a mortality rate of greater than 5%. And probiotic or symbiotic interventions were studied compared to placebo or nothing. But they did include, if they're enteral nutrition, they allowed it if there was a prebiotic. They had, and also the papers had to have a reported clinical outcome. And the primary outcome that was looked at was ventilator-associated pneumonia. So this included 71 studies, about 8,500 patients. And listed here are the most frequent probiotics that were used. So again, differences, we have Bifidobacterium species, Lactobacillus, Streptococcus thermophilus. So you can see there's a variety of different probiotics utilized. So this is what's interesting, I found. So again, I've highlighted in bold, what the result was. Probiotics reduce incidence of ventilator-associated pneumonia. However, when they looked at the grading, they graded the papers based on whether they were low quality studies versus higher quality studies. Most of these recommendations or benefits came from lower quality studies. When they had looked at the higher quality studies, these results did not appear to result. So again, it really leads to question of the quality of the study and how can we actually interpret some of this data. But the other thing that I thought was very interesting is they looked at the adverse and serious adverse events. And I think this is something that, of course, ever since I started looking at probiotics back in the 1990s, has always been a concern with the Institutional Review Board. Are we able to, it's just a good thing to be giving to our critically ill patients. And so what they found is that there were 22 reported, 15 came from higher quality papers. And they found that the probiotics had a higher adverse event incidence than in the control subjects. And most of the reported adverse events were that the probiotic species that was provided were isolated from sterile culture or were the sole or predominant organism from a non-sterile culture site. So summary of the results from this paper were that probiotics may reduce ventilator-associated pneumonia. They also combined, some of the papers didn't really define a lung infection, so they did a combination of ventilator-associated pneumonia and lung infection. May benefit infectious complications, diarrhea, and mechanical ventilation duration. However, these results only came from the lower quality studies, but that the probiotics may be associated with higher adverse events. And so the conclusion from the authors was that the significant risk of adverse events and lack of benefits suggests routine probiotics should be avoided in critically ill patients. So what can we do? We know this microbiome is disrupted. We know that the importance of the microbiome and trying to benefit the host and how important it is to help us with our own immune function. But maybe we're concerned with giving live active bacteria to our patient population. So I thought this study was very clever. Came out in JPEN in 2022. And what they did is it was a prospective randomized controlled trial where they looked at the delivery method of enteral feeding to the patients and how does that impact the gut microbiome. So this was actually a subset of a study where they were looking at, they called it sequential feeding versus continuous feeding. The overall study was looking at nitrogen balance, but they had a subset of patients where they had gotten stool samples and they were able to interrogate the microbiome. So how this went is the patients were admitted to the ICU. They were on continuous feeding until they reached about 80% of their target energy requirements. Then they randomized the subjects to either go to sequential feeding or to stay on the continuous feeding. The sequential feeding, how that worked was they took their nutrient requirements and they distributed it over 3 different time points throughout the day of a 2-hour infusion. So they adjusted the infusion rate over 2 hours times three interventions. So between 7 and 9 a.m., 11 and 1 p.m., and 5 to 7 p.m. And then they looked at the microbiome themselves, looked at what the effects were. So looking at the different feeding delivery methods, there was no difference in alpha or beta diversity between them. However, they found that the sequential feeding did have slightly increased the abundance of actinobacteria, which Bifidobacterium is part of that, that phylum. And it also increased Fusobacterium and Pseudomonas. But what's interesting is they also did metabolomics. So they looked at some of these metabolites that were produced. And of this, they found that sequential feeding increased retinoic acid and leucine. So leucine being one of the branched chain amino acids that's important for maintaining lean body mass. And also retinoic acid is the final end product, the active component of vitamin A. Retinoic acid is actually a very important vitamin. I'm surprised Lintech didn't talk about retinoic acid, but it really helps to increase B cells in our gut to then release secretory IgA from our intestinal enterocyte. And so secretory IgA is one of our biggest immunoglobulins within our gut to help against pathogens within the gut. It also helps to inform dendritic cells within our gut, which then dendritic cells go on to differentiate our T cells into T regulatory cells, the good T cells within our gut. So all of this is really intriguing to me as a means to potentially modulate the gut microbiome without really to avoid, to bypass the concerns we may have with giving live active cultures. So just in summary, takeaways, we know that there's many clinical situations that there's gut dysbiosis, including critically ill. It is an area of target for therapeutic manipulation, but I think we need to be very mindful and appreciative of what data we do have and be clever and try to come up with other ways to potentially manipulate the gut microbiome in a favorable way to help the host. But I think we have to be very mindful of how we do these studies and be in a safe manner. And this is where, you know, good research really needs to be done and not just arbitrarily provide these substrates to our patients without assessing the risk benefit. All right, so I also have some questions, but I was lazy and just did true false. So, so let's go through it and we can just do a show of hands. Okay, first question. Antibiotics only affect pathogenic bacteria. True or false? Who says that's true? Who says it's false? All right, we got that one. It's false. Okay, it takes several days of critical illness before the gut microbiome changes. Who thinks that's true? Who thinks it's false? Yes, we have evidence to show within, you know, hours, 6 hours of a metabolic insult. All commercially available probiotics are equally effective. True or false? Who says it's true? Who says false? Yes, thank you. Please spread that word to all your patients. I mean, everyone's so confused. The data is very strong supporting the use of probiotics in critically ill. Okay. All right. Well, and here's my reference. So thank you so much for your time. The question was, do I recommend having the bacteria in place to produce butyrate, or is it okay to take a butyrate supplement? Okay. Yeah, so there are butyrate supplements available. And what's interesting about those is that most of the supplements are what's called sodium butyrate. And that is, so we have within our gut, starting from our proximal duodenum all to our rectum, we have transporters for short chain fatty acids. So they are expressed throughout our intestinal tract, but most abundant in our colon. So if you take oral butyrate, sodium butyrate, it does get taken up, transported, or passively transported across the inner site in the proximal intestinal tract. So whether that is beneficial in the distal gut is not known. There are some other tributyrin, that's actually what I've been studying, which is a structured lipid of butyrates, and it's a glycerol backbone with 3 butyrate molecules esterified. You take that, it's a lipid, so it has to be digested by pancreatic lipase, but then it frees up 3 butyrate molecules to be absorbed. And I've been studying that in my animal models and actually shown to have a lot of benefit in the proximal colon, but we've also now started doing work in the small intestine, protecting gut barrier as well as intestinal immune function. So it could be this is, where things are going. I think again, has to be carefully studied. I know you can get them if you go on Google. You can find the supplements, but I don't know that I don't use those in my life, but. Sure. Yeah, so they've changed they've changed the nomenclature for a lot of everything. And people are just like frustrated because it is kind of confusing. It doesn't change what's going on, but it does confuse people. It confuses me because like I'm writing a paper now, I have to write like both things because you don't know time, how that's gonna be the thing. Yeah. Yeah, so I think it is confusing and it's going to be harder like in the future to relate it back. So just like Clostridium difficile was renamed, everything's been kind of changed. I'm not sure why. It's like our software. Why do they have to update it when it's working just fine? It's like, oh, so the question is what probiotic decreased ventilator associated pneumonia? So that's where there were several of them. Predominantly lactobacillus species, but they're all different ones were studied. But most of predominantly the lactobacillus GG as well as the plantarum have been the ones that have been studied the most. Yeah, so the question is giving prebiotic. I didn't really talk a lot about that. The data is just starting looking at prebiotics in critically ill. And then how will that impact the production of short chain fatty acids? So not every, just like probiotic, not every prebiotic yields the same amount of short chain fatty acids. So it really depends on what you're doing. So like inulin versus fructooligosaccharides versus resistant starches, you're going to get a difference. And again, the microbes have to be there in order to be able to generate those. The other thing I didn't mention is that in a healthy state, the microbes can cross feed. So they can cross feed lactates into butyrates. Certain microbes can do that. So we're not really sure all the time, like if we give a prebiotic, if it's directly affecting, if it's affecting another microbe that's cross-feeding into this one. So the answers aren't known. And I think you have to be careful, just like anything, if you recommend anybody healthy to give fiber, you got to think about your patients too, coming into your ICU. their general population, most people consume less than 15 grams of fiber per day. So you've got people coming in, you don't know if they eat fiber in a normal setting. You don't want to overload them with prebiotic fiber because that could have a detrimental effect on top of their illness. So gradually introducing into their diet, just like you would in a healthy situation, is important. Yes. So that's a really good question. So we think about intermittent feeding and in general, and then circadian rhythm. And that's where I haven't seen any studies with enteral nutrition. So that's why I was really excited about that one. And but just like we have a circadian rhythm, the hosts, our microbes have a circadian rhythm as well. So looking at and thinking outside the box, should we be feeding our patient nocturnally when that's their circadian rhythm is changing to not metabolize nutrients? And so I like that whole concept of how they did it. They did it when the patients were stable and switched the feeding, but I think it's an important area to look at. Linda. Oh, great. Thank you, Lindsay. So that I'm interested in retinoic acid because I'm studying that in my lab. So, so we've shown that in mice, and this is an alcohol. I study alcohol. It's a good model to use for gut dysbiosis. But with alcohol, so if you give vitamin A, it has to be metabolized into its active all-trans retinoic acid. The enzymes that do that process are decreased in the enterocyte of the mice and with alcohol. So I wonder if, if you give all-trans retinoic acid as opposed to vitamin A, it's like with the question about just giving the butyrate instead of having to, rely on generation of the butyrate. So I think this is where, looking at these different metabolites and can we just give back metabolites to see benefit? But we don't see that with everything because like giving back branched chain amino acids don't necessarily improve muscle and things like that. So. Yeah, very interesting. Thank you. Okay, thanks everyone. Oh, there's a question? Oh, wait. Yeah, okay. Yeah, so the question was about oral microbiome per se. Yeah, so that's a whole and critically ill. So that is a very good question. And, back in, I don't know, 90s, doing chlorhexidine rinses to try to decrease the bacterial candida load in the mouth and that very point of the aspiration and everything actually shows some benefit. But we're just starting to learn a little bit more about the oral microbiome and its relationship with, and a lot of that's been looked at with relationship to cardiovascular disease. Periodontal disease is definitely been in that. But I think it's just a growing area. There's a different microbiota within our mouth than what's within our gut. There's some similarity, but there's definitely differences. I don't think we know enough about it to actually start to target that, but doing the chlorhexidine rinses, I know, have shown some benefit. Yeah, so the question was like trauma patient or surgical patients after their surgery to try to use pre or probiotic to replenish gut microbiota. So there are some studies with the trauma patient population, those actually showed some positive benefit with, again, it's strain specific probiotics. So thinking about why the adverse events of probiotics in the ICU, the sepsis, the sears, these really sick patients like what the ones particularly Lintech was describing, there is a high risk there, right? And a lot of the probiotic are delivered at the bedside. So you have to make a slurry, put them down through the feeding tube, and opening that up at the bedside, they become airborne, and then they can get into the catheter site, into the wound site. But when a patient's more stable, in my opinion, I think that would be a better way to do, to tackle it. But I would probably not just do probiotic, I would do something more substantial, symbiotic or diet. You get everything on board for the patient to try to restore the microbiome at that point. Thank you for the presentation.